So I'm going to present on my own personal experience with the RayOne Trifocal. I've been using Rayna lenses for 10 years now, and so I have a lot of familiarity with the monofocal and the toric platform. And so the opportunity to be one of the first surgeons evaluating the newest trifocal on the market was one that I was very happy to be involved in. I think with any kind of presbyopic intraocular lens, it matters a lot what the characteristics of the patient are. Oliver mentioned, how motivated the patients are. Our patients that we used were all motivated, otherwise we wouldn't have given them a trifocal lens. But a question of their age, the status of the lens in their eye, their refractive status, these things are all very important to try and understand how likely a patient is or is not to be happy. So I'm going to go through each patient that I implanted with this lens bilaterally, and I did 4 bilateral implantations, so it's 4 patients and 8 eyes, and we'll go through them one by one so you have a feel for what these patients were that were receiving the lens, and then I'll present my own results. I have seen the results of the other 4 surgeons that were involved in this initial evaluation, and what they're seeing is very similar to what I'm presenting. So although I'm showing you 8 eyes, there have been, I think, about 70 lenses now implanted, and 40 or 50 in this initial evaluation, and so the results have been quite similar. I'll show you a video of the implantation technique so you can see it, and some observations, and then there will be time for questions at the end. So the first patient was a 58-year-old. This patient had clear lenses, so not a cataract patient, but a vision correction patient. He was hyperopic, and he was offered laser eye surgery, but wanted a more permanent option, so was elected to undergo refractive lens exchange. And we planned for immediate sequential bilateral refractive lens exchange using the RayOne Trifocal. He had less than 0.75 diopters of corneal astigmatism, so we just did on-axis surgery for him. The next patient was a 63-year-old, also a vision correction patient. This patient was a low myope, and traditionally these are patients where you have to be a little bit careful about presbyopic solutions because she was reading N5 unaided preoperatively, so she had perfect reading vision. So in her, these are the kind of more demanding patients where I think you really are getting a feel for whether the lens is able to deliver for you, because if it doesn't deliver, patients will let you know. She had early lens opacities, so we decided to do a refractive lens exchange, again, rather than a laser eye surgery for her. Also less than 0.75 diopters of corneal astigmatism. This patient is what I would consider to be low-hanging fruit. So these are the patients that for people that are just starting to get going with presbyopic lenses or multifocal lenses, you almost feel like you can do no wrong with this kind of patient. This is an 80-year-old patient, bilateral cataracts, barely seeing the legal standard for driving, in fact not seeing the legal standard for driving with glasses, not really able to read very well with glasses, and he was also wearing multifocal contact lenses, and he was happy in those. And generally, multifocal contact lenses I think are quite difficult for patients to tolerate because they move around on the eye, so they will automatically decenter between blinks, and then they also induce dryness, which interferes with multifocality. So I found in my own practice that if patients are happy with multifocal contact lenses, they'll always be happy with a multifocal intraocular lens, providing the surgery is uncomplicated. He also had low astigmatism, and we did phaco and IOL with the RayOne Trifocal. And the last patient, quite young, so again, these patients you also have to be a bit careful of with presbyopic lens options, so only 51, so only early presbyopia, a very low amount of ametropia, so not a big refractive error, but she was bothered about the fact that there was this discrepancy between her 2 eyes, and I think that her presbyopia had unmasked this, so when she was younger, being plus 1.50 in one eye wasn't a big problem for her, but now actually she was no longer able to accommodate through this, and it was a real problem for her. Didn't tolerate having the 2 eyes offset refractively, so again, laser eye surgery not an option for her. And she actually had 1.3 diopters of astigmatism on the cornea in one of her eyes, so we planned to do on-axis surgery and an opposite limbal relaxing incision to debulk her astigmatism. So this is a video, I think, of my second implantation. It's topical anesthesia. I mean, there's nothing special about the surgery, but I think for those of you planning to start using the lens, it's useful just for you to have seen an implantation so you know what's involved. I'm using a 2.4mm incision, but this lens will comfortably go through a 2mm incision with a wound assist, and I use a 2.4mm incision straight into the eye, as you saw Oliver Findle also do. It's a 6mm optic, so we're trying to make our capsular rexus 5.5mm. And I do always, with any presbyopic lens, take a little bit more care over my capsular rexus because I think that any decentration or vault of the lens may affect the outcome, but actually With this particular lens platform, I worry much less about that because it's a very, very stable lens indeed. And for any of you that have used RayOne lenses will know that there really aren't problems of decentration with these lenses at all. Always hyperinflate the bag in the anterior chamber, and it's a one-handed injection technique, which is quite helpful because you can counterfixate the eye. So a bit of viscoelastic goes into the hole that fills up the chamber. It's a fully preloaded lens. You don't have to touch the lens, manipulate the lens in any way. Just snaps shut. It's thin fluid because it's hydrophilic, as are all the trifocals except for the panoptics. And then the non-dominant hand can counterfixate the eye, allowing the dominant hand. So you could do a wound assist here. I'm doing a quarter turn to deliver the lens, but I'm told that the latest version of the RayOne injector doesn't require this. You can just put it straight in and it will go straight in, but it unfolds very predictably, and it's very easy just to dunk the trailing haptic into the bag. And then I always take out viscoelastic from behind the lens. I think that gives you some consistency with your final refractive outcome and your A constant. But you'll see that the lens centers very well. I mean, you could try and move this lens around and nudge it. I mean, you've probably seen the Allon lenses. You can move them left and right. That makes me feel quite uncomfortable because as the bag fibroses, you don't know what's going to happen. This lens just stays in the center of the capsular bag, and you can see the Purkinje images there showing really excellent centration. Now, I've probably put in about 2,000 RayOne lenses, not obviously trifocals, but a lot of experience with RayOne lenses, and it's a very familiar platform. So for any surgeon familiar with the RayOne platform, this is a very easy thing to adopt surgically. It's fully preloaded, easily inserts through a small incision, and the intraocular lens centers well. These are the results then. So these are the first, these are the 4 patients. I would ignore a little bit the monocular vision because with any multifocal presbyopic lens, the monocular vision is always worse than the binocular vision, and actually most patients need to have binocular implantation in order to perceive good vision with any of these trifocal lenses. But if you look at the binocular uncorrected distance visual acuity, the top 2 patients is at 1 month follow-up, the bottom 2 patients is at 2 weeks. The vision was 6.5, this patient, 6/4 in this patient. This patient was a cataract patient, 6/9, and this patient again 6/5. So most patients achieving better than 6/6 vision or better than 20/20 vision. Intermediate vision, monocularly, again, you can never really achieve more than N6 with any trifocal lens because, well, with any presbyopic lens because you're holding the chart at 75 centimeters and anything smaller than N6 or J2 is just too far away to actually be able to see. So this is about as good as you could possibly get. And then here with the reading vision, and I think this is where long-term studies, I think, will, in my opinion, show that this lens will outperform its competitors because they're all seeing N4 or N5, and these patients were telling me on day 1, day 2, how amazing their reading vision was. I noted, I mean, Oliver didn't talk about how he was generating his refractive results. I'm not sure how the other surgeons were either, but in my practice, I have an optometrist with me all the time, so all of my refractive results are optometric refractions, no auto-refraction. This is actually an optometrist doing a subjective refraction with the patient, asking them what lenses they prefer. So some patients were about minus 0.25 in the 1 week time point, and those patients all tended to emetropia by the 1 month time point. All patients reported halos at night, but none of them complained of it, so all patients were happy. And neuroadaptation was very fast. And in fact, if I wasn't evaluating the lens, wanting to know what the longer term outcomes were, I would have discharged all of these patients at 1 or 2 weeks because none of them had any significant complaints and all had excellent vision. My feeling is it's a forgiving lens. It's zero aberration optics, which means that small amounts of refractive error, small amounts of cylindrical error. For example, I don't think that I completely neutralized the corneal astigmatism on the 51-year-old patient, but if she was left with half a diopter astigmatism, it certainly didn't bother her. And that's something that I think is very comforting in these kind of lenses. I had no early cases of posterior capsular opacification, but I do expect that I will have some because with all trifocal lenses, patients are not tolerant of posterior capsular opacification. So if there is posterior capsular opacification, I expect the patients to come back to me for a YAG, but nothing in the early series. One patient had a large angle kappa, so the lens centered perfectly in the capsular bag, but his visual axis was not in the same place, and you do see this in some patients. But again, the patient didn't complain of any problems, so it's forgiving of angle kappa, which maybe some of the competitive lenses may not be. And and a very high percentage of patients achieving better than 6.6 and N4 for reading unaided. I mean, the only thing I would say is for any patient getting going with presbyopic lenses to not view it as the same as a monofocal lens. Obviously there are extra things that you need to be careful of and make sure that you optimize, and patients need to be counseled appropriately, but certainly no additional counseling for this lens compared to its competitor products. So in summary, I've given you a case-by-case summary of my first 4 bilateral implantations, that's 8 eyes, in my own private practice. You've seen a video implantation technique, my own observations, and there will be some time for questions. I'm very happy for people to email me directly or get in touch on social media if you have other questions about my own experience with this lens. And now I will take any questions.